Do you have incontinence, and are you afraid to talk about it? But don't be.
Now stick around to the end because we're going to answer the question that we know everybody has, and that is, do Kegel exercises actually work? And we really want to encourage people to talk about this issue, and that's why we're going to be talking about it on Talking with Docs.
Welcome to Talking with Docs. I'm Dr. Brad Wiener.
I'm Dr. Paul Zalzal.
We have a guest today, Dr. Carolyn Best. She is a urogynecologist, so has a very special interest in this topic and an expert, and she's going to share her knowledge with us this morning.
I was so excited about this topic, I nearly lost control of my bladder.
Okay, so we're going to start at the very beginning because people don't always understand exactly how our anatomy works. Dr. Best is going to explain what's the bladder and why it matters.
The bladder is an organ at the bottom of our pelvis whose only role is to collect and store our urine until we are able to go to the washroom and empty it.
Okay.
I mean, you'd think that organ would get a bad rap, but really that is one of the most important things that an organ can do, is help us get rid of waste.
And to be honest, many of us would like to ignore it, but a huge message that I have is that you can't ignore it. You have to pay attention to it. And if you do ignore it, you tend to end up with some issues.
Okay, and both men and women have them. Today we're talking about primarily
Women.
This is a female issue today with Dr. Best. And so what is the bladder? How does it start to fail us over time? Why does it cause us problems?
A number of reasons. The bladder is basically a passive vessel that will just collect all the urine that's created by the kidneys. So people don't often know that. And so all we know is what we feel. Our bladder's whole job is to give us a sensation when it reaches a certain volume that needs to be emptied. And we never know how much is actually in there. All we know is what we feel. And so it's those feelings that can become bothersome.
And that starts when we're kids, right? That's how kids get bladder trained, right? They get that signal, right?
We learn what those feelings mean. Sometimes in our busy lives, we choose to ignore those feelings, like lots of healthcare workers that do very long surgeries, nurses or teachers or other jobs, or even just having a busy life. And the point is, we can't ignore it. Over time, it will allow us to hold more and more, and that can lead to more problems.
And some people almost have this as a point of pride, but it's really, we shouldn't do this.
No.
Right? Like, oh, look at me, I went 9 hours and I didn't have to go pee.
Right. A normal frequency of voiding that's normal function would be about every 2 to 3 hours.
There's your first take home.
It's not a great thing to be able to hold 4 or 5 or 6 hours and be proud of that. So that's a normal frequency. In terms of women, the biggest risk factor for developing problems with our bladder is pregnancy and vaginal birth, but also just living life. Women at all ages can get bladder problems. It does become more common as we get older in terms of certain types.
And you'd say, go ahead, Paul.
I was going to say, why pregnancy? Why does pregnancy do that?
Well, the impact of pregnancy on the pelvic floor. So the pelvic floor is a diaphragm of muscle that is at the bottom of our pelvic and abdominal cavity, through which the urethra passes through, which is how we eliminate urine, right? Passing through the urethra. So pregnancy has a huge impact on the pelvic floor, both being pregnant, carrying a baby, but also having a vaginal birth. Unfortunately, inevitably, it's a normal process, but it will create some damage to the pelvic floor, depending on the type of birth and the factors there, that needs to be rehabilitated. So we don't often know that, and it's something that's actually ignored.
And is that like cumulative? So if you've had one baby, it's like a certain risk, 2, 3, 4.
Well, to be clear, some women get bladder problems and incontinence with no pregnancies. So I want to clarify that for those women out there. One vaginal birth has an impact, but the greatest risk factor would be 2 or more vaginal births.
Okay.
But a C-section is not protective. You can still get issues, of course, with a C-section delivery. And then, of course, there are other kinds of incontinence that we develop later in life that are independent of whether you've had any pregnancies.
Okay, so beyond pregnancy, what would the other risk factors be?
Okay, so there's a number of lifestyle factors that can impact your bladder function, whether you develop incontinence. Unfortunately, being overweight can be one factor. Smoking is another risk factor. Constipation doesn't help either. And lifestyle in terms of what we consume and the fluids and the foods that we choose to drink and eat.
Okay.
Specifically, bladder irritants or things that we drink, such as caffeine. I like coffee.
Yeah, so do we. Paul does not drink coffee.
I do not.
I do.
You do not drink coffee?
It's so
I used
odd.
to drink Coke every day for my caffeine, and now I cut that out too, except for on weekends.
And alcohol can also impact bladder function as well. Those are bladder irritants. So these are all things that can impact it, whether you've had any pregnancies or not.
Many of our videos where good times go to die is our channel where we say, don't do this, don't do this, don't do
That's
this.
what I thought.
Yes, so we keep it real though.
There's a lot of side effects and risks associated with alcohol that we have been talking about.
So the other risk factors I would assume would be certain neurological disorders can predispose us to this?
Well, medications and medical conditions overall
Right.
can predispose you to certain kinds of incontinence or just make the treatment more complicated.
Okay.
But there are some specific neurologic conditions that will make it more likely, yes.
Okay. And then the last one, what about menopause? Menopause is such a difficult, common issue for so many women
Yeah.
that we've talked a lot about on our
Yeah.
channel. Does that increase your chances of having incontinence?
No, not directly
Okay.
in a way that we know, but it can heighten the symptoms.
Okay.
So menopause can increase sort of the sensations of the bladder, can create more irritation, more urge to pee, but it doesn't necessarily cause incontinence on its own. But there is more of an age-related factor there. Most women in menopause are beyond the age of 52, and the older we get, no matter whether we've had any pregnancies or not, certain kinds of incontinence become more common.
All right.
Okay, there's a good one for menopause, something that doesn't have a negative effect on you.
Okay. So incontinence is a really big topic. Are there different kinds of incontinence just so that people can know?
Absolutely.
Okay.
There's something called urgency incontinence or urge incontinence, which manifests as the sudden urge to pee, like you better run to the bathroom or you're not going to make it, and
Right.
you don't. Some people get urgency and not incontinence, but that's a very big one.
Okay.
Another type of incontinence is stress incontinence. This is extremely common as well. This is leaking with any kind of increase in abdominal pressure. So urine leaks out with a laugh, a cough, a sneeze, a jump, a high impact exercise, lifting something, or even yelling.
Right. Like the trampoline.
The trampoline is the worst.
Right.
So
Watching Jerry Seinfeld while you're on the trampoline.
definitely.
There we go.
And then there's something called mixed incontinence, which is really just means more than one thing together. Most commonly, urgency incontinence and stress incontinence together.
Okay.
You can also get something called overflow incontinence, which is more complicated and less common, which manifests as dribbling or random leaking in the setting of someone who doesn't empty their bladder properly.
Okay.
What's the most common one? What's the most common thing that you see in the office? If you see someone coming, you're like, I bet you this is going to be. Is there a most common one?
Well, no, it depends on the age and the demographic, but I would say that overall population level, probably urgency incontinence is the most common.
Okay.
But urgency incontinence, stress incontinence, and then mixed incontinence are all very close. I would say I see mixed incontinence the most, just because that's a little bit more complicated to treat.
Right. And so as we start to get further into this, you would tell people though that the impact that this has on people's lives varies. And you as an individual get to decide, hey, if this is bothering me, regardless of how serious it is, this is why you should talk to someone, see a healthcare provider, and get some treatment.
Absolutely. I mean, let's be real. I would say at least 50% of women experience some kind of incontinence in their lifetime.
Yeah.
But only half of those women will actually say something about it.
Right.
They're too afraid or embarrassed or ashamed. And so they also get the impression that it's normal.
Right.
So when something is really common, it doesn't mean that it's normal.
Right.
So that leads to a lot of women suffering and not doing anything about it per se.
That's incredibly high, like
Oh, yeah.
prevalence, 50%.
Yeah.
So I would say a huge takeaway is just talk about it. Talk to your doctor about it, but also talk to your friends and your family members about it, because that creates a culture where people are more likely to get help for it, and they're suffering kind of in silence.
Okay. So someone's come to your office, they've been
Yes.
referred, you've done the history, so you've talked to them all about this, you've determined the typical type or if they have multiple types of incontinence. What is your next step as far as physical examination and diagnosis to confirm your diagnosis or make a treatment plan?
Well, let me first say that lots of primary care physicians will help people with incontinence. So I'm not the only person that sees them.
Sure.
But when things become a bit more complicated, I take a really detailed history, including all the things I just said about what kind of incontinence is it. A lot of the time we can get enough information just from talking about what it most likely is, whether it's stress, urgency, or mixed. What's most important in terms of tests is to do a urine test to rule out infection.
Okay.
Because it's important for people to know that a urinary tract infection can create incontinence on its own, can actually do anything, including create incontinence.
Okay.
So that's very easy to treat. What I also like to do is examine people to make sure there isn't anything physical that could be the cause by the time they come to me,
Right.
but also do some kind of assessment of what we call the post-void residual, which is how well does the bladder empty. That can be measured most easily by ultrasound
Okay.
or a bladder scanner, because that will impact our treatment options and how complicated it is to fix.
Okay.
Wow, so you get the history, and it sounds like a lot of things, most of the diagnosis is made through history.
Sure.
A physical examination is involved there, and then those tests that you order as well, specifically rule out a urinary tract infection,
Yes.
and then check how the bladder's emptying. Okay, and with that history, that physical and the examination and those tests, can you diagnose it pretty much for sure, or is there still?
A significant amount of the time we can. There are some treatment options that, depending on the type of incontinence that comes out with talking, that we can try right away without any more tests beyond that. If people come to me and they've already tried different things, or we try something and it doesn't work, then we can go on to more specialized testing.
Got it.
Let's talk about those things that you can try that don't involve too much medical involvement.
All right. So first of all, I talk to people about behavioral and lifestyle changes, some of which we already mentioned. Cut down the caffeine, cut down the alcohol. Carbonated beverages can also be bladder irritants. These are all things that will increase the sensation of needing to go and be diuretics to fill up the bladder faster, like we were talking about how the bladder works.
Okay.
I also talk to people about smoking and about their overall fitness and health, because these things are all related.
Yep.
I also talk to them about their bladder habits. So this is a huge thing that I talk about a lot. What are healthy habits that help? A normal frequency is peeing every 2 to 3 hours. Sometimes people just keep a bladder diary and record how often they're going. And then
Dear diary.
Yeah.
I just peed.
Exactly. And how much did you drink?
Okay.
Right? And what did you drink?
Okay.
I thought that was a journaling in the washroom. That's what that is.
That's right.
He's already working on it.
Hear me dropping my pen in there.
Yeah. Once you have an awareness of what you're doing, there's something called bladder training, where you can literally train your bladder to go for longer periods of time, slowly, to train it to go for longer periods if urgency and frequency is a concern. What I really want to emphasize to people is the role of pelvic floor physiotherapy. So these are professionals that teach us how to maintain strength of that pelvic floor that we were talking about, that can help with all kinds of incontinence and maintaining that tone over the course of their life, just like any other muscle in our body, right?
So this is where the name that a lot of people are familiar with, where Dr. Kegel's name would come into place.
Correct.
Right. So he was an American gynecologist, and in 1948 wrote a paper that said, hey, I got this device to measure the strength of the pelvic floor, and I've been using it to treat these people with incontinence.
So Keel exercises are very well known, just like you just explained. Keel exercises have been known as just tightening and squeezing. What's important is that many people are not doing it properly.
Right.
So you have to be taught. They've actually done studies to show that giving someone a handout or saying, do your Kegels, is not effective. You have to actually demonstrate it, and that's where physiotherapists have really taken off, and the field of pelvic floor physiotherapy is really exploded.
So they actually monitor you do it and give you like feedback on how well you're doing this Kegel.
Exactly. You can tell when you do a pelvic exam. There's a number of things you can assess on a pelvic floor exam of the strength, and they can assess how strong the contraction is and guide people appropriately on what to do to improve that. But it's not just about tightening and squeezing. Like any other muscle with a full range of motion, you have to contract and you have to completely relax.
Right.
So it's a functional strength. And so it's not just as simple as doing your Kegels.
So a lot of people say, oh, I tried Kegels, it didn't work for me.
Correct.
Most often, if that's true, they may not have been doing them properly.
The importance is also consistency.
Okay.
All of us like a quick fix. We all know that these problems don't develop overnight.
Right.
So it involves repetition and period of time. So some studies indicated that 6 weeks of consistent, 3 times a day, 10 to 20 repetitions is what it takes to get improvement. And in women who are consistent with that, especially for stress incontinence, where it can have a great impact, 60 to even 75% of women can get significant improvement.
75% success rate for a non-operative, simple method that you can do on your own.
Well, yes. And then involving a professional in terms of making sure that you're doing it appropriately with physiotherapy.
Okay. So you'd want to find someone that's specifically qualified for this.
Yes.
Obviously, the average physiotherapist does not specialize in this.
Well, you have to have qualifications, and certification in that. And so they know what they're doing.
Sure.
And so anyone who advertises pelvic physiotherapy should have had that certification.
On that note, I'd love to ask, you see all of these ads for fancy devices and chairs and balls that you can sit on that purport that they can do 12,000 Kegels in 10 minutes. Is this something that, I think I know the answer, is this something that can replace Keel exercises?
My short answer is no. I would say that there's lots of great technology that has been developed. People are continuing to develop, which is amazing. I'm trying to make this easier for women and to get the word out. But so far, the science doesn't show that anything that's a technology can replace the role of a physiotherapist.
Right.
It might increase the uptake. People might be more willing to go if they can go and be fully clothed and sit on a chair that will create contractions for them.
Right.
But it's not necessarily better. Unfortunately, it also has a cost related to it that is prohibitive for some people.
I think that's a really good way to look at it, because often we talk negatively. Sorry. I think I just peed. often we talk negatively about like technology or pharma or something that are making a product that they're trying to make money and it may not really work, but you put a nice spin on it because at very least, even if it doesn't work, it's encouraging the conversation about it.
Absolutely.
Which is one of the problems in this issue, is that there's not enough conversation about
There's not enough conversation, and yes, exactly. I would say that I think any technology that that is safe, first of all, because there's no evidence that there's any risk,
Okay.
is to increase awareness is great. It takes time for the science to show whether it works or not. So it also let people know that.
Okay, so continuing under the conservative window, we never really talked. Pads obviously are an option for someone that says, listen,
Yeah.
mine's a smaller issue. I'm happy to deal with it, or I don't have the money or time to go to physiotherapy. So pads, I guess, would be your first line. Is that fair? Or a first thing to discuss? Not first choice, but
No.
an option?
Yes, of course.
An option.
So
Okay.
pads are always an option to protect yourself. That's something people do at the beginning. There's a few cautions with pads. It can be very irritating to your skin.
Okay.
That can be a problem for long-term use. I would also say that, unfortunately, the pad advertising indicates just put on a pad and you're fine.
Sure.
And I think that is a disservice to women because it encourages them more into the realm of, well, I don't have to say anything. I can just put on a pad.
Accepting it.
But not knowing that they can actually get help with it.
Right, and a lot of celebrities are now endorsing these too.
Sure.
And I agree with you. It just sends a bit of an odd
normalizes it,
message.
But it says, this is all you need, which is not really fair in my personal opinion.
Okay.
It's like a Band-Aid solution.
It's a Band-Aid solution.
Yeah.
Like a
I
big
forget what else you
Band-Aid.
asked there. What else did you ask me?
No, beyond. So we go pads and then Kegels. And then what would be the next under the conservative umbrella?
Yeah, be careful with what you're drinking and what you're consuming, like I mentioned. And then being aware of good bladder habits, going regularly, not waiting too long.
Right.
And for people that have a problem with peeing during the night, being careful with what you're drinking, nothing with caffeine or alcohol, especially afternoon, and avoiding fluids at least 3 hours before bed. I also have to talk about water.
Okay.
Water is the best thing to drink, but there is no science that we need to drink 8 glasses of water per day.
Wait, what?
Yeah, unless you have
agree
been
with
that. Yeah.
medically advised because of your medical condition that you need all that water, that isn't a real thing. I would say be careful with how quickly you're drinking water. The faster you drink, the faster you will have to go to the washroom to pee.
Right.
So sips throughout the day is better.
And they make those jugs now.
Yeah.
Massive that have like,
Well, the thing I
Time
know
of day on
is
it.
that those people spend a lot of time in the bathroom.
yeah.
And that's cool if that's your choice. But if
Yeah.
it's a problem that's affecting your life,
Right.
look at how much water you're drinking. The same recommendations don't apply to everybody. So not everybody needs to drink that much water.
You'd be journaling all day long, right?
Correct.
I need more pages in my journal.
If all conservative measures, everything I've just said doesn't help, it depends on the type of incontinence where someone like myself will become involved. You can treat certain kinds of incontinence with medications.
Okay. So we're going to the medical surgical type of treatment. So
Yeah.
which type of medication, what class of medications are typically used for this, and how do they work? What's the thought behind them?
So there's a couple of different classes of medications that we use particularly and only for overactive bladder.
Okay.
There have been medications created and tried over time for stress incontinence, generally not as effective as the other things we use for that condition. The classes of medications including one group called anticholinergics, which is a long fancy name, but that's a class of medications that decrease the bladder muscle activity.
Okay.
So we were talking before about what the bladder does. It has a wall of muscle whose job is to contract, give us sensations, but also empty when we're on the toilet. The medications calm the muscle down to reduce the urgency and the frequency and the leaking for people with overactive bladder.
Okay.
Overactive bladder is the name for people who have urgency incontinence,
Okay.
where they have frequency, urgency, getting up at night to pee, and they may or may not leak at those times as well.
Right.
So there's another class of medication. Do you want me to talk about this?
Yes,
Yeah.
I think
Called,
they do.
Beta agonists.
Okay.
Which there's really only one at the moment. Its name is mirabegron, which is a medication that will work in a similar but different way to relax the bladder wall muscle to reduce those sudden urges or sensations of needing to pee or the leaking associated with it.
It's like ADD of the bladder.
And you know what? Now that you say that name, I've seen that on my medication list of a lot of my patients, and I was thought, oh, what is mirabegron?
Now you know.
Now I know.
And so do you.
So overall, both of these classes of medications are most of the time very safe to use.
Okay.
There are always going to be interactions with other medications you have to consider. Overall, they're well tolerated, but there can always be side effects with everything.
Okay.
Common side effects would include dry mouth or constipation. So those are points of conversation whenever we're considering doing this, is sort of the benefit and risk ratio with someone's quality of life. If they're significantly impacted by their incontinence, despite trying everything we just mentioned, sometimes it's worth a try to help their quality of life.
Okay.
Okay, so here we go. We've done the lifestyle, sort of the physiotherapy things you can do. Then there's the medication things
Yes.
you can do. Are there surgical interventions? that you can do?
Absolutely. But let's be clear about when we do surgery.
Okay.
So urgency incontinence or overactive bladder and stress incontinence, which I mentioned, are two separate conditions. So overactive bladder or urgency incontinence can be helped by medications. There are treatments beyond that I haven't mentioned yet, but not really surgery. Stress incontinence is the only kind of incontinence that's helped by surgery.
Okay.
So stress incontinence is a physical weakness of the pelvic floor or the strength of the support to the urethra where we pee out of. And that loss of strength allows the urine to escape with those laugh, cough, sneeze, trampoline jumps, or whatever. So because it's a physical problem, the solutions are more physical. So it's the only kind of incontinence that's surgically treated.
Right.
Many people think, well, my medication didn't work, I need a surgery.
Sorry, there is not an operation for
Those
this.
are two separate conditions.
Right.
The exception is people who have mixed incontinence. Sometimes we have to do more than one category of things to help those people because they technically have more than one condition.
Mixed.
Very carefully with more conversation and nuance there. So there's surgical management of stress incontinence, and that's the only one that's helped with surgery.
Gotcha. Okay, and then mixed, you're saying might have.
We may have to do more than one thing. We always try conservative behavioral lifestyle changes first, pelvic physiotherapy for everybody. We may try medication before surgery for people with mixed incontinence because if it gets there, because medication can be stopped. Medication, people don't like to always take it.
Right.
We don't have to take it necessarily forever, but a trial of that is something we would try for someone with mixed incontinence before we get to surgery.
Surgery's a one-way road, typically.
It's an invasive treatment that we only do if we really need to in specific scenarios.
And the principle of surgery is to try to support the floor, that muscular floor or diaphragm that was supporting our bladder that has been damaged by life and time and the rest of it.
Yes.
Yeah. Okay.
I would say specifically to the urethra itself.
Yes.
You can't fix stress incontinence without putting something in somewhere.
Okay.
So there's different surgical options that involve putting something to reinforce the urethra to help with that leaking.
Okay. So can we talk a little bit about that?
Sure.
What are we putting in? So I guarantee, leave a comment, please. If you've had an experience with incontinence or if you've had surgery or some type of treatment that worked for you, didn't work for you, please share it. But someone's going to ask, what's a pessary? And is that something that we can use for incontinence? Because typically I think people think about it for prolapse, but it has multiple roles. Is that fair to say?
Of course. So I didn't talk about that.
Yes.
But pessaries are also great options for stress incontinence mostly. So pessaries are a vaginal device that will create extra pressure and support from underneath the urethra to help create that physical support like I mentioned. There are a few different designs. There's some that I have in my office. Sometimes I will fit a patient with one.
Right.
And there are some you can also get online, which are also very effective.
Okay.
So that's also not a surgery, of course, but that's a
So somewhere in between the two.
physical support, that will create help with stress incontinence.
And then just for people to understand the principle, so it goes inside of your vagina to make a block. Are you able to void while that's in place?
Yes, you are.
Okay, so you can overcome
should be
that.
Able to.
Okay.
Some pessaries are, removed every day. Some women have control over when they use it. So if they're going to go to the gym, if they're going to go play baseball, or they're going to play volleyball, or go jump on a trampoline on purpose, they can put the pessary in specifically for that time period. Some pessaries you wear all day, all night.
Yep.
So yes, you do need to be able to pee with it in.
Okay.
So that a pessary should never actually block your flow. It's not a plug.
Okay.
It's a support. And so it's just changing the anatomy and creating support where the support has been lost.
And it is a reusable as opposed to a disposable device.
Absolutely. So there are
Okay.
disposable devices that have been created where that would be a cost associated with that if you're using it long term. Even though you may be investing in a pessary with a cost there as well, they can be used for years.
Okay.
So I have patients with pessaries that have had them for 10 years.
Okay.
Wow. That's a classic pessary.
That's a long time.
Pass that down the generations.
I don't think you pass it down.
All right, I need a little summary because that's a lot. I'm going to go back and watch this video a few times personally, and you may want to as well. But we just a little summary. Bladder is a muscle.
Yes.
Okay.
It has a muscle wall.
Has a muscle wall. Its role is to collect urine from the kidney, store it, and then excrete it
Yes. When we
Okay.
want it to.
when we want it to. And that's where the problem is when you can't no longer control
Yes.
when to excrete it. And then the different types are
urgency incontinence,
urgency incontinence,
stress incontinence,
stress incontinence,
mixed incontinence.
and mixed
Those
incontinence.
are the most important.
Those are the most important. In order to control this, the best thing you can try first are the lifestyle changes. We talked about the things to avoid in your lifestyle. And then there is some physiotherapy that you can do to strengthen the muscle. And then for certain types, there's medications that can help.
Yes.
And for certain types, surgery may help.
And for certain types, you can use pessaries as well.
And for certain types, there's devices.
Yes.
There you go. Excellent, Paul. That is A+.
See that?
Gold
He
star.
learned. He
He
learned
really
today.
did.
Listening
I like
with
it.
docs.
Okay, so now you know all about incontinence. The most important take-home message today is that this is very common. Please talk about it. Talk to your friends about it. Talk to your family doctor about it. But don't be shy. It is definitely a very treatable, potentially reversible problem that needs to be discussed more.
Yes.
And to answer our question that we asked at the beginning, yes, Kegels work almost 75% of the time if you do them
Properly and consistently.
and consistently.
Yes.
And just remember, if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health. That's your best.
Thanks so much.
Thank you.
Yeah, that was awesome. See you next time.